Adrenal disorders can be confusing sometimes, but in this video we will differentiate between them and know the treatment agents in 7 minutes or less. Adrenal gland hypofunction will result in primary adrenal insufficiency or Addison disease, while the hyperfunction of the adrenal gland that is associated with high cortisol levels will result in Cushing syndrome, and the excessive aldosterone levels will result in hyperaldosteronism. Now let's dig deep into the pathophysiology and the symptoms that is associated with these conditions. The adrenal gland have essential roles in regulating blood pressure, metabolism, and managing responses to stress. To do that, they secrete the following hormones: cortisol, aldosterone, and adrenaline. Now for cortisol, it increases the glucose levels by promoting gluconeogenesis, which is an essential step in responding to stressors. For the aldosterone, it regulates the blood pressure and balances the levels of potassium, sodium, and regulates the blood pH levels. Now, how this hormone gets secreted? Well, the adrenal gland is controlled by the hypothalamus and the pituitary gland. So the hypothalamus will produce the corticotropin-releasing hormone and the antidiuretic hormone or ADH. These hormones will stimulate the pituitary gland to release the adrenocorticotropic hormones or ACTH, which finally stimulate the adrenal glands to produce the corticosteroids like cortisol. Now in adrenal disorders, what happens is, in Addison disease, since we have hypofunction of the adrenal gland, we will have low levels of aldosterone and cortisols. For the aldosterone, it results in hyperkalemia, hyponatremia, acidosis, so the patient will be hypotensive, will crave salts, and feel fatigued and dizzy all the time. For the low cortisol, it will result in low glucose levels, so the patient will be disoriented and feel tired all the time, and the low cortisol make the pituitary gland more active, promoting melanocyte-stimulating hormone, which will result in hyperpigmentation for patients. For Cushing syndrome, we will have high levels of cortisol that will result in high glucose level, resulting in high insulin, which will contribute to fat redistribution, causing moon face, central obesity, and buffalo hump. Also, the patient will be hypertensive because of the amplifying effect of catecholamine, which happens by the cross-reaction with mineralocorticoid. Because of the similar structure of mineralocorticoid and cortisol, so the excessive cortisol will bind to the mineralocorticoid receptors. Now for hyperaldosteronism, high aldosterone will cause hypertension and result in hypokalemia, hypernatremia, and alkalosis. Now what about the treatment options? For Addison, we need to compensate for the low levels of cortisol, so the treatment agents are the glucocorticoids, like hydrocortisone, cortisone acetate, and prednisolone. 2/3 of the dose should be given in the morning and 1/3 in the evening to mimic the normal cortisol secretion. Side effects include Cushing syndrome and GI side effects. In primary adrenal insufficiency, the fludrocortisone is administered to compensate for the mineralocorticoid loss. For Cushing syndrome, it is the opposite. We need to lower the cortisol levels. So our treatment options are: first, ketoconazole, which reduces the cortisol levels through the inhibition of several cytochrome B enzymes, but the efficacy of this treatment agent appears after several weeks of the therapy. Now for the side effects, it has an anti-adrenogenic activity, so it can cause hypogonadism and gynecomastia in men. Also, it may cause reversible alleviation of the hepatic enzymes. Second, we have etomidate, which is similar to ketoconazole, but it's only available in parenteral formulation. Now the third agent is the metarabone, which inhibits the cortisol synthesis, but the problem is that the patient may have an increased ACTH concentration because of the sudden drop of the cortisol levels, which will increase the androgenic and the mineralocorticoid hormone, thereby causing hypertension, acne, hirsutism, and other related side effects. Now mitotane reduces cortisol production by blocking the cholesterol side chain cleavage and the 11-beta-hydroxylase. The onset of mitotane action is slow, but with sustained action that can be maintained for several months after discontinuation. Side effects may include hyperpigmentation and GI side effects. Now for Cushing syndrome that's caused by the corticotropic tumors, they can be treated by the following agents: caprigoline and basirotide. Corticotropic tumors contain receptors that interact with dopamine and somatostatin. So for caprigoline, it's a dopamine agonist, and the dopamine action in its receptors has an inhibitory effect. Side effects include GI side effects and dizziness. For basirotide, it's a somatostatin analog that binds to the somatostatin receptors, which are expressed in the corticotropic tumors. This will decrease the ACTH secretion and proliferation. Side effects may include ketoacidosis, sudden dizziness, and hyperglycemia. Now for hyperaldosteronism, we need to lower the levels of aldosterone, so our treatment agents will be: first, spironolactone, which is a non-selective aldosterone receptors antagonist, and the side effects can be GI discomfort and hyperkalemia. Second, we have apelerinon, which is a selective aldosterone receptor antagonist and has a low affinity to progesterone and androgen, so the associated side effects will not be present here. Third, we have amiloride, which is a potassium-sparing diuretic, but it's less effective than previous agents, so it can be used as adjunctive therapy. And that's it for this video. I hope that it helped you to review your information about adrenal disorders and their treatment options. And if it does, please share and like the video.